This is Jeff Higginbotham with Advanced Pain Care. I'm a board certified pain management doctor. I'm here today to talk about my most fun topic in the world is pain management. I could talk about this all day. I really just love what I do and I love everything about it. So it's a blast to be here, and it's a blast to get to share some of my knowledge and just expertise, but also just the fun parts of it, and just kind of give people an understanding about what we do and all the things that this encompasses. I think very few people understand what all we do in pain management. So hopefully I can kind of guide y'all through this today. I'll kind of tell my story a little bit first about pain management. It's funny, I had no one in my family that was in chronic pain, had no idea that the field that I chose for my life even existed. It's funny, I worked my way all the way through medical school into my anesthesia residency and had no idea about pain management. We had some rotations, it's interesting, in anesthesia residency where they talked about chronic pain, and I asked some of my buddies, like, what is this? And they were like, oh, don't worry about it, that's just a couple months that you need to do. Just get in, get out, and you'll hate it, and then you can go on and do the things that you love to do. It's funny, I showed up there the first day with no expectations, and I absolutely fell in love with it. I literally realized that the specialty that I just give my heart and soul to was something I never knew that even existed in life, and realized that there's so much that we can do. And I think that is a big sort of, I don't know, misconception, or like even just a lack of understanding about pain management. I don't know how many patients I see every day that come to see me that have no idea what options there are for chronic pain, which that doesn't surprise me in that, heck, I made it all the way through medical school and didn't know that there was options out there for that. I had never had any back pain or any issues like that, and to find out that there are those things out there has been a huge benefit, and realize that we can really do a lot of good work to help people. So it's interesting, when we look at pain management as a specialty, I wear a lot of hats. And I talk about my hats all the time with patients, and it depends on where they're at and what's going on. One of the things that we work with a lot is back pain. So I consider back pain a symptom, not a diagnosis. There are lots of things that cause back pain. My analogy, which I used in clinic today, was you go to the doctor with abdominal pain, that's not a diagnosis either. That's just a symptom. It could be appendicitis, it could be a bad gallbladder, it could be colon cancer. They're all cause abdominal pain. In the same sense, back pain is very similar. So one of the things that we do when we work through it is to try to figure out why you have back pain, or why the person has back pain. A lot of times, if we can do some diagnostic work, we can look at it, we can actually make it where we can understand why the person has pain. When we get to that point, then we can look at actually helping and try to fix the pain itself. One of the issues with pain management and just looking at a lot of spine-related pain is that, unfortunately, when we look at x-rays and MRIs, a lot of them are abnormal. But just because it's abnormal doesn't mean it's actually causing patients pain. There was a big study where they ran like 1,000 people through the MRI that never had a history of back pain ever in their life, which is actually not me. I've had a little bit of back pain before, but I wouldn't even qualify for this study. But what they found is like 70% were abnormal. So one of the things I do when we look at it is we try to figure out why the person has pain. Some of the things that we do via some of our injections and things like that are as much diagnostic as they are therapeutic. We're trying to figure out the reasons why they have pain. Once we do that, like I said, then we can work on treatment options to try to help it. Sometimes within the injection phase, we can actually help it. Sometimes it goes back to the rehab phase, sometimes surgical. So we sort of work through those things on the other side. Secondarily, one of the things that we do is work with, and I work with pain from head to toe. So there are certain things where we know why they have pain. They have debilitating rheumatoid arthritis, or really bad osteoarthritis, or weird, not weird, but like unusual nerve pains, which are very rare for people, but we see them all the time. And we already know what's causing it, and we try to work on avenues to fix it the best we can. So when we look at pain management, there are lots of avenues and different things that we do. And what I actually find is with a lot of patients, it's the little things that all work together that actually make people better. Sometimes I think pain management gets there's some misconceptions there to assume that and people are afraid to come see us because they just don't want to be on narcotic pain medications. I will tell you from my perspective, if I could fix people in every other way and I never had to prescribe another narcotic pain medication, that would be the best day of my life. I really would prefer to look at other aspects. There's some great studies over the long haul that show that they only provide about 30% relief of pain. So, that's great if, if we're sitting there and life is miserable, but if we can look at lots of aspects. So when we look at pain, just in general, there's multiple facets on how we actually treat pain. Some of them are super conservative, and some of them fall into what we call complementary alternative medicine. And that becomes the physical therapy, chiropractic, acupuncture, some behavioral therapies as well, cognitive behavioral therapies. And then we also look at, within my world, interventional therapies. Some of them are identifying pain generators like we kind of spoke about before and trying to figure out why. And then we do some palliative options like spinal cord stimulators, which is, we can talk about it a little bit more, but it's really where we try to work on the patient who we know has chronic pain that there's no surgical options to fix, and we try to see what we can do to just manage the symptoms. And then there are surgical options. At Advanced Pain Care, we have neurosurgeons that work with us that we can, once we get it targeted, even if I can't fix it, we can still get that person help, and we can work forward to try to look at long-term sort of options related to pain management. One thing we look at when we're looking at chronic pain is it's not a one-size-fits-all. It's so individualized. I've got students that follow me periodically, and I always, when we're discussing patients after I see them, we always discuss, some of them ask me, well, why did you do this with this person and not this with the next person? And it's interesting, and pain management is a very individualized sort of thing. It depends on where they're at, where they come from, their goals and where we actually go to treat them. It's a very individualized care. I joke with my students sometimes. I said, I can see 5 people with the same condition and I might treat them 5 different ways. They're variations. They're kind of similar. They're cousins of each other, but we all have to work through the individual aspect to try to see what we can do to try to make life as good as we can. I always discuss with them and patients as well is I'm a function person. What I want to know with a patient is what can't they do because of their pain, and that when I hear, and they will tell me that all the time. I do an office out here in Bastrop. I spend half my day trying to get guys back on their tractors again. And I think, they'll come and tell me that, I can make it a little bit around the field, but when I get out there too long, that bumping around that tractor really bothers my back. I've got to stop, go lay down. So that's an easy goal, where maybe a hard goal to accomplish, but an easy one to identify. So therefore, later on when we work with them, I ask them, how far can you go on your tractor? Can you do those things? Sometimes we get caught up in pain management about a 1 to 10 pain scale. That's less important as much as functional gains. We'll see a lot of patients here in Central Austin that their golf game gets affected, which, one person might say, well, the person can still walk, they can still make it around. But sometimes if you can't do the activities that you enjoy, that's the start of depression and just the, lack of motivation to do lots of things. I joke the one time that I ever felt depressed in my life, I like to run in the mornings. It's my social hour. I meet my friends every day. We go do this. And I had an Achilles injury, which I couldn't run for almost 6 months. And I say that was probably the closest to true clinical depression that I've ever had. It's funny though, I never even knew it until I was able to run again, that I retrospectively looked back and realized how bad life could be when you can't do the activities that you really enjoy doing. And I'll see people through all those shades of that aspect. One of the things we look at with pain management just in general is expectations. And I will tell you, sometimes we joke that in pain management, we fix the unfixable, or we help the patients who no one else can help. A lot of times we get referred patients that no one else knows what to do with. So, and a lot of times, a lot of other specialties have another person to fall back to. When we look at pain management and we're like, well, we can't help them necessarily, and you turn around and look, there's no one to send them to. You'll find something to do. So when we look at those things and we look at what we can and can't do with a patient, we have to evaluate, what is the expectation? Do they want this pain gone? Do they want it a little better, or those sort of things? And sometimes I will look at a patient, we have mismatch, where sometimes the condition is not quote unquote fixable, but it is manageable. And if a patient wants it to go away, now we have a mismatch on what is medicine is allowing us to do at this present time and what we can actually offer a patient. So those are the things when I sit down and visit with a patient, we try to work through and try to see if we can all get on the same team. I'm a realist by nature. I hate just optimistic, fluffy bunnies and unicorns that are not realistic, that are not optimistic, or not real at least. Let's work through this rationally, scientifically, and try to see what we can do to try to make it as good as we can. There is not an uncommon time for me to see a patient that says, if I have to live like this, I don't want to live anymore. I see it more often than one might want to believe. But it's always a pleasure to me to see that patient later on, after I tell them that it's going to be okay, we're going to work through it. At some point, we're going to come back and talk about your grandkids, and we're not going to talk about your pain anymore. And I'll see the person back, and we'll talk about randomness and their hobbies and kids. And at the end of the visit, I'll say, how's your pain? And they look at me and they're like, still hurts, but I'm okay. And I will tell you, that's a big step, and those are big things that we work with. I mean, would I love to bless everyone and make them better? Sure. One of the stories I tell all the time is about my magic wand. I joke that every day when I put on my scrubs, I look for my magic wand to bless everyone and make them better. I said, I've never found that magic wand. It doesn't stop me from looking every day. But until I find it, we're going to try to do whatever we can to try to make life as good as we can. And science evolves. There may be a time later on in life where, and it may be beyond my lifespan, that some future doctor is going to look back on the things that we do today and think, oh my goodness, how barbaric that they did these things to people, or this, these treatment options, they were bloodletting or leeching. And, unfortunately, I don't live 100 years in the future, so I have to do with what we've got today. And we try to use all the tools and all the things that we can to make a person as good as we can, the best version at least that they can be. It's interesting. One of the patients that I see a lot is the patient who is actually a candidate for spine surgery. So one of my hats and one of the jobs that I do all the time is to see how many of them I can prevent from having to need back surgery. So I always joke I've got an interesting relationship with the neurosurgeon. They send me patients, I see how few I have to send back to them. Unfortunately, they don't starve. So there's a subset that no matter what I do, it's a surgical problem. That being said, there's also some solace there to know that the day before a person's back surgery, they can sleep easy at night. They know that we have exhausted every option and we've tried our hardest to try to avoid that back surgery. And unfortunately, it is time. So at that point, they can at least sleep easy and not go into surgery with the what ifs. What if I'd have tried this one more thing? Or what if we'd have done this? No, I touch all the bases. We try to cover all the aspects of things to make sure that we get everyone as good as we can. One of the other things I see a lot is the very elderly person with really, really bad backs. And one of the stories, I actually told it this morning, was about a guy I saw a couple years ago that he was 88 years old, and he came to see me out in Bastrop, and his back was as squished and twisted as I've ever seen a back. And I look at his imaging, his scans, and I looked at him, and I think to myself, what the heck am I going to do for this guy? So I got in there, I looked at him, we talked about it, and I said, hey, I'm not sure if I can make you 18 again. And he leans in and looks at me and he said, you make me feel 70, I'll be all right. So I think with that, I don't even know if I could really do that, but I sure as heck have a better option at that. And that's matching that realistic expectations with what we can and can't do. We do see the miracles at times where we'll do one injection, or I'll put one of the spinal cord stimulators in and they literally get 90 to 100% relief. It would be great if I did that every time. Those are my victories. Those are my wins. Those are fantastic. But those wins are actually the small part it's making the little impacts in people's lives. I think that's the most important. If I can knock their pain down to get that person to the mailbox, get them to the grocery store, get them around where we can just like improve their function at all, sometimes that's actually more of a win for me than the few and far between that we just magic wand and bless and make them better. When we look at some of the things that we do, we kind of touched on just a little bit ago about spinal cord stimulation. So definitely not a topic that I'd ever heard of before becoming a pain management doctor. No one in my family's ever had anything like that. But also, I was lucky enough genetically to no one in my family's also had back surgery. So, but when we looked at it, we realized that back surgery doesn't fix everybody. Or it'll maybe fix part of it, but there's not all that's left over sometimes. So that's one of the major advances in science, is the ability to actually place little electrode filaments or electrode wires basically up into the backside of the spine to basically block out nerve pain from the back down to the legs. Is it 100% successful? Is it perfect for everybody? No. But if we looked at, we kind of briefly said that with medications, people get about 30% relief of pain. Spinal cord stimulation is about the only thing I've ever seen to get somebody long-term 70 to 80% relief of pain, which, I mean, that beats medicines any day. And it also allows person, if they do well enough, to actually maybe not even have to take medications at all. They can set it and kind of forget it and hopefully go on and live as much of a normal life as they can. I mean, there may be always limitations in the same way as the 88-year-old guy that I talked about before. There's always going to be potentially something that we can or can't do despite all treatment things. But the more tools we do, the better off people are. So sometimes it's all the little things that we do, and it's the combinations of things that actually make the best outcome with it. It's interesting. One of the things with spinal cord stimulators that we talk about a lot is one of the classic patients is the patient who had already had back surgery, that it helped, but not all the way, and that their pain kind of came back. And when we look at their imaging and stuff, they probably could have another surgery, but a revision surgery is a big back surgery. It makes the first one, the recovery is dramatically longer. Their success rate goes down quite a bit with it. So a lot of times either I or we'll work with the neurosurgeons to look at, and there's quite a few neurosurgeons that send me patients that say, yes, we can operate on this person, but it's a big back surgery. It could be a 6-month recovery. Why don't we try a stimulator first? With the trial portion of this, it's the only thing we can test drive. You can't test drive back surgery. You can't put it in and then if it doesn't go well, back it up and pretend like we didn't do it. No, it is what it is once it's done. But a stimulator is one that you can actually put it in temporarily, see how they do. If the person comes back in a week and says, oh my gosh, why didn't I try this 2 years ago? Fantastic, they do great. Or if they come back to me and say, didn't help me as much as I wanted to. Okay, that's okay, we've at least tested, we've tried. At the end of that week, I pull the little electrode wires out, there's been no cutting, no sewing, no nothing. It's basically like an injection, nothing more, nothing less. And a lot of these patients that we've worked with have also had epidural steroid injection, which is a very classic technique that basically every pain management doctor in the world does. And I always joke with them, it's like doing an epidural steroid injection. The only difference is I put the wire in instead of putting steroid medication in. But at the end, we back the little needle out, tape everything down, send you home for a week, and you come back and tell me whether it was the best or the worst week of your life. At the end, like I said, it's no harm, no foul on that other side with it. That being said, also with it, it's kind of nice because we didn't burn any bridges. That person, with the neurosurgeon that sends me a patient like that, we can trial the stimulator. If it doesn't do as well as you want, that's okay. We didn't prevent them from potentially having that big back surgery with the 6 months recovery. We've at least dotted all the I's and crossed all the T's and know that maybe that is the next step in treatment on that person. So I think in the end, when we look at a lot of options, there are tons and tons of options out there. And everybody's a little bit different, and I think it takes that individualized, tailored approach to actually try to get the best outcome for everybody. And I find that even within the behavioral things, and I have a lot of people that are get nervous when we talk about behavioral therapy. They're like, I have pain. I'm not crazy, and I get that, and that's not what we're after. I know we have pain. Unfortunately, pain beats people down. Pain really just drags life down. I always joke that a patient can tolerate severe pain if they know it's getting better. But it can be low pain. It could be just, if we're going on that 1 to 10 pain scale, it could be 3 out of 10. But the fact that you go to bed with it every day and you wake up with it in the morning and it doesn't go away, over time, it doesn't matter how big on that 1 to 10 pain scale it is. It really interferes with entire life and function. So sometimes with that, kind of working through the psychological aspects of understanding and being familiar with it and realizing that despite it, it's going to be okay and we're going to make it. And we're, maybe life looks a little different than it ever has before, but it doesn't mean that life is over. And we can still work through these things to make you as good as we can. And, I think when we work through all those things, we do a pretty good job trying to help improve patients' pain and lifestyle on that aspect. I've got 1,000 other stories and things that I could talk about, but I'm probably running low on time. But thank you for having me today.